worst of all the worst. Worst because the incidence of meningitis is relatively more. It cannot be said for certain at this juncture of time, but it has been found out that the incidence of meningitis following a single short spinal is about 1 in 1 lakh. With a continuous lumbar epidural is 1 in 1 lakh to 1 in 1 lakh 20,000. But with CSC, it is 1 in 20,000. So till we reach equal number of CSCs as there have been spinals and epidurals, we cannot say with certain, but it has been proposed or hypothesized that because there is a rent on the dura and subsequently you're threading the catheter, there is a track, there is a transcutaneous migration of the bugs into the epidural space, and if there is a bloody tap or if there is a blood collection inside the epidural space, there might be increased incidence of meningitis. Especially Dressner et al. First time in 2006 reported a case report from Leeds wherein Staph aureus was cultured from the anesthesiologist's nose and the patient's CSF. So it was direct transmission from the anesthetist to the patient, and that's when the routine usage of CSC was questioned, and there are few indications you have to stick to the CSC. Coming to continuous spinal analgesia, we have done about 4 to 5 cases using CSA kits, but they are very expensive, cost around 5,500 rupees, and it offers no extra advantage except that you are using ultra low dose. The local anesthetic toxicity can be minimized, but even Arkush et al. In their extensive study, which was done under the guidance, under the watchdog of FDA because of the microcatheters and cauda equina syndrome, they reported that the incidence of catheter failure is almost about 8 to 10%. And there are more technical difficulties to thread this 28 gauge catheter into the subarachnoid space. And the incidence of transient neurological irritation was relatively more. So at this moment of time, it is one more technique, but not a routinely recommended technique. There have been lots of research on the newer regimes, maintenance regimes for labor epidurals, especially the low-dose ambulatory regimes. The concept of minimal local anesthetic concentration, minimal local anesthetic volume, MLAC, MLAB, MLAD are in vogue. And it has been said that the MLAC for bupivacaine is 0.042, MLAC for ropivacaine is 0.047. Because the MLAC for ropivacaine is relatively more, the toxicity also is relatively less. So it is not that ropivacaine is superior in terms of reduced toxicity. It is just that it is less potent compared to bupivacaine. Walking epidurals, yes, not all women, especially in an Indian psych, in our scenario, we have found that they're not willing for ambulation, especially because once they are relieved of pain, they would like to sleep or they want to relax in the laboring suite. But it has been recommended that any technique, you should give a technique which allows ambulation. That is, your technique should be less motor, more sensory block. And that's where the concept of low-dose epidurals, which is, when I say low-dose, it is the concentration of local anesthetic less than 0.125%. And ultra-low dose is less than 0.08% of local anesthetic, bupivacaine or ropivacaine. And the maintenance, you can maintain with continuous epidural infusions, you can maintain with patient-controlled epidural analgesia or parturient-controlled epidural analgesia. You have computer-integrated PCEA pumps, and you have automated mandatory boluses, which have been studied extensively in Singapore by Alexia. And what these pumps, they do is, of course, the continuous epidural infusion, the elastomeric pumps we were using, but we have abandoned its use because the incidence of motor blockade after 4 hours of continuous infusion is almost 70 to 80%. Even with low-dose mixture, that is 0.0625 or 0.1% bupivacaine, the incidence is very high. And what we practice is either PCA or intermittent boluses. PCA is like gives more maternal satisfaction. It requires minimal breakthrough doses, and the computer-integrated pumps they automatically, depending on the number of push the patient gives in an hour or preceding 1 hour, either the computer either steps up the boluses or steps down the boluses if the pump pushes have been less. So it is titrated to the patient's requirement, patient's needs. And this was a landmark study published in 2010, wherein they found out that large volume, low dose mixtures are much better than low volume, high concentration mixtures. This was a blinded RCT, which was published in 2010. The myths and controversies, which the concerns, like obstetricians concerns mainly is, does it cause backache? The patient concerns, does it cause backache? The anesthetist concern, does it increase the incidence of low force, use of forceps? Well, there have been extensively studied, and it has been found out by the extensive Cochrane review in 2005 that epidural doesn't increase cesarean section rate, it doesn't increase the long-term backache. The UPGAR are not affected. Maternal satisfaction of penile is relatively good, but yes, it does increase the instrumental delivery rate. And when you are using, how do you minimize the instrumental delivery rate? Basically, this was a study that was published in, again, 2008 by Fraser et al. The people study, that is pushing early versus pushing late. Because once the woman receives the second, reaches the second stage of labor, till the station is at +1, do not encourage the mother to push. This is one of the most important things which every practicing anesthesiologist need to know, because if you encourage, can I have 2 more minutes? If you encourage pushing in the second stage of labor, the moment, if the station is less than 0 or -1 or 0 station, you're deflexing the head and you're arresting the rotation of the arresting the rotation of the descent of the fetal head, and you are increasing the second stage, you are increasing the instrumental delivery. So this is very important that you push, delayed pushing is better than early pushing. Timing of epidural, whether you early epidural increase the cesarean section rate or the early epidural increase the cervical dystocia. And in fact, this was a paper that was published in 1986, and subsequently the ACAG came up with a statement saying that if possible, the epidural should be delayed till the mother reaches a dilatation of 4 centimeters. And this was a joint statement given by American College of Obstetrics and Gynecology. It was just a matter of time that RCT was produced, and this was a landmark study again in 2005. It was a multicentric study, and they said that epidural given early in labor does not increase the cesarean section rate. And it was, there were a few more studies following that. And again, the ACOG redefined the statement and said that epidural can be given on maternal request at any stage of dilatation. You don't have to wait for 4 centimeters dilatation. Post-cesarean section analgesia, there have been a lot of exciting research. Again, the TAB block, the transverse abdominis plane block, either blind technique, the anatomical technique or ultrasound guided, is a thing which is very good, especially when you're giving single shot spinals. You can give bilateral 20 ml 0.1% bupivacaine with clonidine. It gives analgesia for 15 to 20 hours. And extended release epidural morphine also is available, especially if you're giving a single shot spinal. I have found out the intrathecal morphine, just 200 to 250 micrograms of morphine, works very well as a post-operative analgesia, because the incidence of pruritus is less than 40%. Incidence of respiratory depression, especially with hydrophobic molecule like morphine, also is relatively low. Yet to encounter, we have done more than thousands of cases of intrathecal morphine. But especially in pre-eclamptic women where they have renal insufficiency, they have renal failure, bottle and creatinine, and you want to give good analgesia, there is no epidural catheter, your NSAIDs are contraindicated, just give about 200 mg of intrathecal morphine. At least for next 10 to 12 hours, they have good analgesia. And then subsequently, you can club it with paracetamol. The risk management is very important. Whenever you practice labor epidurals or obstetric epidurals, you need to minimize the adverse effects, and intralipid is a rescue for inadvertent intralocal anesthetoxicity. And co-syntropin have been used. Prophylactic co-syntropin has been used after inadvertent dural puncture, and it was published in Anesthesiology in 2010. They said that co-syntropin in the dosage of 1 milligram, each one of us must have done Senaxin test, which is nothing but you see the stress response of the adrenal corticotrophin secretion. So co-syntropin is, the only thing is the cost factor. 0.25 milligrams costs around 500 rupees. But 0.5 milligrams to 1 milligram prophylactic, even we have used about 5-6 cases last 3 years. We have found that the incidence of blood patch requirement is relatively less. Of course, in our hospital, it's a protocol last 7 years that the moment you have an inadvertent dural puncture, we always thread the catheter intrathecally. The incidence in our hospital is 0.3%, but we have found that the requirement of blood patch is reduced significantly. Probably once we have a large number, then we can say we can give the p-value. And there's a lot of controversy. It has been found out again that when the patient has paresthesia, when you're giving epidural dose, better not to give a dose, withdraw the catheter, reset the catheter if the paresthesia still persists. Because it has been found out that when you're injecting a drug through a 10 ml syringe, the pressure that you are generating are almost 20 to 30 pounds per square inch. And in 10% of the patients, it goes up to 30 pounds per square inch. And the break point to break the neurolemma is just 11 pounds per square inch. So suppose if your tip of the catheter is intraneural, or it is into that sheath, then you're going to rip off the sheath and the patient is going to end up with neuropraxic or neuronemesis, nerve injury. You need to remember this mind. So it is better not to use 20 ml syringe or 5 ml syringe, because the pressures you are going to generate during injection are very high. And moreover, when you are generating high pressure during injection, the 0.2 micron filter, the bacterial filter, which is epidural filter, is going to breach and going to break, and it's no longer going to be protective from bacterial infection. And if you are, for some reason, if you are keeping the catheter for more than 48 hours, change the filter. You need to have pamphlets, adequate monitoring. Do not compromise on metal monitoring, especially high-risk obstetric patient. See that you have all the monitoring tools in place. And there have been enough papers on coagulopathy and anticoagulants and regionals. You need to keep yourself, you need to have your protocol. ASRA has given 2 excellent guidelines in 2010, and most of the time, probably AORA will also come out with its own guidelines down the lane. But do not rely on BTCT. BTCT is an obsolete investigation. Always go for better investigations like PT, APDT, or platelets when you're doing a block in a patient with coagulopathy. The block that does not regress even after 6 to 8 hours, you need to keep this patient a safety net and go for early MRI, especially with gadolinium scan, because especially if you're doing an obstetric regional in a patient who is having coagulopathy or in preeclampsia with HELLP syndrome, then you need to keep this patient a safety net, and you need to have your own early diagnosis, because it can be catastrophic if you have a delayed pickup. In order to improve your work, you need to have your introspection, your own audit, and your own ways to improve your statistics or maternal satisfaction. Generally, we have every monthly we have our own audit, wherein even the procedure, pain related to procedures, is audited, and we try to keep minimize the patient comfort. Like if you see the procedure related comfort, severe pain was there in 7% despite adequate local. So always you have to have your own standards and keep raising your standards so as to give higher maternal satisfaction. And of course, always keep alternate methods of pain relief in hand, and you need to have care and concern. Good communication with the entire team is important. And one of the most important thing, as I said, the Why Mothers Die has now changed to Saving Mothers' Lives. And if you see the anesthetic cause, which was the third leading cause in 1950s and 1960s, with the advent of regional anesthesia, it is the last cause of direct deaths of maternal mortality. And more or less, last 7 or 8 years, the anesthesia-related maternal deaths, these are the UK statistics. We don't have our statistics in our country. But the direct cause of anesthesia as the direct cause is one of the last cause of maternal mortality. So to conclude, I would say that regional anesthesia in obstetric is the gold standard. But when you're practicing regional, do not forget your airway skills. Very important, because as an anesthesiologist, this should be your prime guard. PCEA is very exciting, and because it improves the maternal satisfaction. Tab block is a good alternate for post-cesarean analgesia. Ultrasound training probably in future will become mandatory. Welcome to Hyderabad for the Obstetric Anesthesia Conference in September. Thank you.
I request Dr. Shailesh Mulgaonkar to kindly present the memento to Dr. Sunil Pandya. Our next lecture is on anesthesia for microvascular surgery.